All right. Good morning, everybody. For those of you that traveled, hope everybody had a good meeting down in Austin. It's nice to finally be back in person and actually see faces in 3 dimensions, not just on the computer here. So this is a bit of an off week. Like I mentioned before, Dave was kind enough to push his talk back because we scheduled his talk right in the middle of AMSSM. So thanks, Dave, for doing that. So today our speaker, Dave Robinson, he's initially from Michigan, did a physical medicine rehabilitation residency out east at Spalding. He's the current fellow at Mayo Clinic Square in Minneapolis. And after this year, he's actually going back out to Boston to rejoin the team out at Spalding. So his talk today is going to be going over a case of distal intersection syndrome. And with that, Dave, go ahead and rock and roll.
Good. Okay. So thanks, Dr. Cruz, Dr. Hoffman, AMSSM for the opportunity here. Like Dr. Cruz had mentioned, we'll be talking about distal intersection syndrome. And it's really a kind of an overview of the complete diagnostic scan of the dorsal wrist. So we got to start with my gratitude slide. Big thanks to Dr. Jelsing, who's my program director here, Dr. Payne and Dr. Johnson up at the Square for all their ultrasound teaching, as well as Dr. Selin and Betcher down in Rochester. Other big important people in my sports medicine training so far is Dr. Asplin and the athletic trainers all at Mayo Clinic Square, Amanda, Brandy, Cody, Josh, Nicole, and Kate. And of course, back to my residency and all the ultrasound and human art mentors there at Spalding and Mass General Brigham. Apparently it takes a village to train me. So the learning objectives today are going to be to understand the scanning protocol for a complete diagnostic ultrasound evaluation of the dorsal wrist. That'll be the majority of the talk. Then efficient, informative diagnostic report writing, and hopefully we can learn something new and have a little fun doing it. So we'll start with our case. It's a 70-year-old right-hand dominant female, came in with left wrist pain for a diagnostic ultrasound. This pain developed a few months after being diagnosed with a subacute distal radius metaphysis fracture. She localized her pain to the dorsal radial wrist, just distal to the radiocarpal joint, and the pain worsened with wrist extension and thumb movement, things like texting, etc. She denied any numbness or weakness. On her examination, she had mild swelling over the dorsal radial wrist. There was tenderness over this area of swelling, but no tenderness elsewhere throughout the wrist. Range of motion was full, but passive wrist flexion was provocative. And then with wrist extension and resisted thumb extension, she had pain. Otherwise, strength testing was negative for any pain or weakness. And her sensation was intact to light touch and pinprick throughout. So it's important before you do these diagnostic scans to compare it to prior imaging. And in our patient, we had radiographs as a prior imaging. With her pain being kind of dorsal radial wrist, that's where our focus was. You can see a little bit of sclerosis here, so from bony remodeling from her distal radius fracture. Otherwise, pretty unremarkable for her area of pain. I just have 2 views here. So the scanning protocol for the dorsal wrist, there's things we need to get, and then things we can get pending the clinical question. Things we need to get: radiocarpal joint and the distal radio-ulnar joint. Then when it goes into the tendons and muscles, there's our dorsal compartments. There's 6 of these with 9 tendons, as well as the extensor retinaculum. Ligament-wise, we always get the dorsoscapholunate ligament, and then the superficial radial nerve. But luckily, the wrist and the hand, there's lots of small structures which are really amenable to being scanned for pathology via ultrasound. So pending the clinical question, things that I've seen scanned, or I know you can scan, and I'm sure this list is not exhaustive, include the proximal and distal intersections. Based on the title of our case, we'll definitely be scanning these things today. A dynamic extensor retinacular impingement, the duct nerve, a little more ulnar-sided stuff like the ulnar carpal joint, the TFCC, ECU. You can look at the pen. You can do that when you're doing your 4th compartment scan. And some of these more unique, smaller ligaments like the radiotriquetral or scaphotriquetral ligaments, important for like dorsal triquetral fractures. the STT joint, and the first CMC joint. And I'm sure there are many more that I didn't list. So things to consider when you're planning your dorsal wrist ultrasound evaluation is, can you answer the clinical question with ultrasound? The majority of the time it's yes. There's a lot of small superficial structures that you can see. You can see that list is pretty extensive. But there are some things that are deeper or a little bit more difficult where you might find yourself often getting an MRI. And that's the time when the patient comes in with a referral for a dorsal wrist scan. You have to ask yourself, is there a very high likelihood I'll be getting an MRI? And should I be proceeding with this scan? Usually that's not the case, but something to consider. And then transducer choice. So typically we're going to be using our linear transducers or the hockey stick. With the linear, you can consider the footprint size and the frequency of it. I'd say this is one of our more standard kind of medium, larger footprint linear transducers, or you can get the small footprint linear transducers, a little higher frequency. Things to consider too is when you're using this a little bit bigger footprint is you can see kind of some overhang here based on the size of the wrist. So you might have to do a little gel standoff. You want to get that pretty picture, or else you're going to have some black space on the corner. And then the hockey stick can be really useful for evaluating even smaller structures and things like nerves. And then positioning. So for the vast majority of the dorsal wrist scan, there's two positions that I use. There's some exceptions to this, but typically it's going to be the forearm pronated, and that can be plus or minus under a pillow for kind of patient comfort and opening up things like the radiocarpal joint for ease of access through procedures, or the forearm in a more neutral position. So the focus area of our scan today is this dorsal radial wrist right here. So we're going to do the complete scan of all the structures we talked about basically being kind of required for a complete scan, but also those additional pending clinical question structures that kind of fall within this little circular radius here. I thought this is kind of an obligatory picture to include in a dorsal wrist ultrasound presentation, showing the cross section of our extensor compartments. I'm going from radial to ulnar. We know there's 3 compartments that have 2 tendons, compartment 1, 2, and 4, and then 3 compartments that have 1 tendon, 3, 5, and 6. The hard ones for people to remember typically when you're kind of getting started is 1, 2, and 3. And just remembering going from radial to ulnar, it's longest, brevis, longest, brevis, longest. People have other mnemonics, but these are the ones that are a little bit more tricky. We see here at the star Lister's tubercle. People often use this as the home base for the dorsal wrist evaluation, kind of starting here and then sliding either radially or ulnarly to evaluate the compartments of interest. So let's dive into our scan here. Look at all the important stuff. So we're starting with the radiocarpal joint. I like to do this in kind of a long axis view to the radius. Oftentimes you're going to be a little bit ulnar to Lister's tubercle. So I have here a picture of kind of where the transducer would be on the hand, as well as when applicable, I try to include an anatomic model. So on the left side of the screen, you see the radius, the lunate and the capitate. Overlying that's usually going to be your 4th extensor compartment tendons. Just throw on the Doppler often to look for hyperemia, synovitis, increased vascularity. Other things you look for in this area would be like ganglion cysts or arthritic changes, etc. In our patient, but the radiocarpal joint was normal without any cortical irregularities, hyperemia, or masses. So after the radiocarpal joint, I like to go into my extensor compartments. So starting with that first extensor compartment, I typically start that, so I can move this, you can see the little picture, with the wrist in more of a neutral positioning. I think it's a little easier to see the compartment, starting kind of over the distal radius, and you can see tendon sheath and the 2 tendons. Oftentimes they're hard to distinguish. Sometimes there's a nice septum between the 2. There's a lot of anatomic variability. So one thing I do is I kind of start here, as you see on this right side of the screen, and then I'll just translate a little bit distally, and then you can sometimes get a little more lucky and actually see these tendons start to separate into their individual tendon sheaths. So we have the APL, remember longest brevis, so the APL is more radial, and then the EPB, which is going to be more ulnar. So for our patient, things we're looking for: fusion, Doppler, thickening, hypoechogenicity in the tendons, but it was normal with no evidence of tendinosis or tenosynovitis. So that Lister's tubercle is kind of our home base. Here radially, we have the second compartment. Ulnarly, we have the third compartment. You can see in our patient, this doesn't look as smooth as we expect typical bone to do, like we saw when we were looking at the radiocarpal joint. So I put, for the distal radius, there were cortical irregularities seen about Lister's tubercle and just proximal to this along the distal radius. So I start on Lister's tubercle, fall off ulnarly, and that gives you a little bit prettier picture of the second extensor compartment. Again, we're looking for the same things in these compartments, the tendon thickening, effusion, hyperemia, etc. So we have our ECRL radially and our ECRB ulnarly. I like to get a still image of that. But since this is a patient where we have that kind of dorsal wrist pain, thought it prudent to scan both the proximal and the distal intersections. So on this right side of the screen, you can see kind of the anatomic depiction of the two intersections at the wrist. So this is the second extensor compartment. We have our brevis going to the third metacarpal, our ECRL going to the second. As we go proximally, you see the first compartment intersecting or crossing over. If you went distally, you would see this third compartment or your EPL crossing over. For the intersections, it's both things are crossing over the second compartment. When you're going for the proximal, it's going to be the first compartment first crosses over your longus, whereas from distal, the third compartment will first cross over your brevis. So it's kind of scan at short axis to the second compartment. So I do this, I kind of center the probe initially on Lister's tubercle, fall off radially to get over that second compartment. And as you scan proximally, you start to see the musculotendinous portion of that first extensor compartment crossing over. And you're looking kind of between these two areas here where they're crossing over for signs of effusion, tenosynovitis, thickening, again, etc. Looking for intersection syndrome. So for the proximal intersection here, I put it was normal in appearance with no evidence of tenosynovitis. The third extensor compartment gets a little repetitive, but you start on Lister's tubercle again, then you go ulnarly. You can see the EPL kind of sitting right here. We have our fourth compartment over here. Often the pin sits kind of in between those two. In some patients, between the third and the fourth compartment, you'll get a bony ridge, which makes delineating the compartments a little bit easier. Alternatively, you can have them kind of wiggle their thumb to better identify the EPL. Then we go into the distal intersection. So there's a few ways to scan the distal intersection. I usually start short axis to the second extensor compartment. So we look up here, now we're going to be scanning distally along that second, or that kind of short axis to the second extensor compartment for the distal intersection syndrome, trying to maintain as perpendicular to the second extensor compartment tendons as we can. So on the left, we have our case here. So we're starting over the second extensor compartment. To the right side is ulnar, which is where our EPL is going to be crossing over. And we can see the EPL is crossing over now. And as the EPL is crossing over, we're starting to see increased kind of anechoic fluid surrounding the second extensor compartment tendons. And remember, it crosses over the brevis first. So there's a predominance of that kind of fluid collection around the brevis tendon, ECRB, versus in a normal case. And this is reversed. So now this is ECRB, third compartment crossing over the top. We're not seeing that fluid collection. I think it's a little better depicted kind of right here. So if you compare the two, you can see the difference side to side as far as the tendon sheaths are kind of surrounded by this anechoic fluid collection, just distal and at that distal intersection syndrome area. So you know, one view is no views, right? So doing the same thing and long axis to the ECRB. This is our case on the left. And you see the EPL crossing over it. And again, you see that kind of fluid collection surrounding right at that intersection location. Compare that to the normal, on the contralateral side. Not as pretty of a picture, but regardless, you get the point. You're not seeing that fluid collection kind of surrounding the tendons at that intersection. And then we throw on the Doppler, looking for hyperemia, signs of increased vascularity, etc. And that gives us our report for the second extensor compartment. So if it was abnormal, there was a fluid collection with the second extensor compartment sheath at the intersection where the third crosses over the second, and it was predominantly around the ECRB. There was some mild hyperemia noted in this fluid collection, but no significant fluid collection surrounding the ECRL. The tendons themselves didn't appear too hypoechoic or thickened without any evidence of tendinosis or tearing. So we scanned and kind of trying to keep the probe as perpendicular to the second extensor compartment. So we're going to do the same thing, trying to keep it perpendicular to the third extensor compartment, which is a little more difficult because these ones go in a more kind of like pure up and down plane, whereas this one is obliquely kind of crossing over towards the thumb. So you're going to kind of translate or rotate the probe in this orientation. And I'll restart this. So we have ulnar here, so this is our ECRB, ECRL, and this is the third extensor compartment crossing over. I'm trying to keep this the perpendicular and short axis. And as it's crossing over, you can see that kind of fluid collection surrounding the EPL as well. And then distally, you're again seeing that fluid collection surrounding the EPL. I thought I had this little animation going before the video, but you're trying to scan short axis to the third extensor compartment for there. So getting both. That leads us to the kind of findings for the third extensor compartment. Abnormal. There was a smaller but present fluid collection within the third extensor compartment surrounding the EPL tendon, again at that intersection of the third extensor compartment crossing over the second. There's minimal hyperemia. I did not save a picture of that. The EPL tendon itself was normal without any significant tendinosis or tearing. So you might think we're done. We covered the distal intersection syndrome. We saw the pathology of our case. But as we know, usually we save things that are pathologic or we think they're going to be pathologic for last because we don't want to miss other things. So we must continue our scan. The fourth extensor compartment has the EDC or the extensor digitorum communans, as well as the EIP or the extensor indicis proprius. And you can see here, I usually just have patients kind of wiggle their fingers. You can try and isolate the EIP by having them just extend their index finger. Again, looking for any abnormalities within the tendons themselves. Some of you can also see kind of in this view where you're getting that third compartment, the fourth, and the fifth over here is the distal radial ulnar joint, looking for signs of cortical irregularity, widening, or obvious abnormalities. And within this fourth extensor compartment area, there is that dorsal radial wrist. There's a few other things we can scan. So we can kind of just scan distally to evaluate for dynamic impingement of this fourth extensor compartment being impinged upon when it's kind of bumping into the extensor retinaculum. You can see kind of on this MR study with wrist extension, you can kind of get almost like a dynamic impingement, similar to like our subacromial impingement. So you're looking for fluid bunching, hyperemia, abnormal thickening of the retinaculum or the tendons themselves. So I scan kind of distally a little bit past the radiocarpal joint and have the patient extend and flex their wrist, looking at the extensor retinaculum, looking for signs of bunching or fluid going between the two, or any other abnormalities or defects in the retinaculum itself. So the fourth compartment was normal, no evidence of tendinosis or tenosynovitis, no evidence of dynamic impingement upon the retinaculum with wrist extension. And then the pen, this often sits between the posterior interosseous nerve, often sits between the third and the fourth compartment. We usually say it's in the fourth compartment. I find it super hard to see a lot of times. So with our new machine we got, I like to use the different settings. And I think with the nerve setting, you can actually see it pretty well right here. And it's often next to some vasculature. And pen's important here for procedures. You don't want to nick it when you're doing a procedure, but also some people will do a block with anesthetic of the pen for kind of denervating the wrist for pre-surgical purposes. So there's a pen. And then the extensor retinaculum. I know we saw it distally when we scanned over the fourth, but I like to do it kind of at our home base region as well, with listers being on the left, and kind of just scanning around in this region for the extensor retinaculum, looking for signs of thickening or any obvious defects within it itself. So again, the retinaculum. And here I put the extensor retinaculum as normal with no evidence of thickening. And you can kind of see the retinaculum here just kind of courses throughout the dorsal extensor compartments, and they often have little dividing kind of subsheaths going down in between them. And then the fifth extensor compartment, our extensor digiti minimi, seeing that kind of right in this area. I try to put a little arrow by it, and I often have the patient just wiggle their little finger to see it. Again, an area where there can be anatomic variance. So typically you're going to see it kind of lying just over the distal radial ulnar joint, but sometimes it can be pretty hard to delineate it from the fourth extensor compartment. It could even be kind of encompassed within that region. So having them wiggle their little finger is a good way to identify it. And for the fifth extensor compartment, there was no evidence of tendinosis or tenosynovitis. There's somebody wiggling their finger. And last extensor compartment is the sixth, the ECU. So this is like one of the caveats to the typical wrist pronated or wrist in a neutral position. Oftentimes just kind of where it is, it's easier to get that pretty picture when you get that wrist and still more of a neutral position with their elbow flexed, so you can get good access to it. Identifying in the ulnar groove, you can see the supratendinous portion of the kind of sheath as well as the infratendinous portion. You can do plenty of other things here like dynamic scanning, etc. We didn't do that because this was a case of dorsal radial wrist pain, so just got the static image of it. For the sixth extensor compartment, it was again normal, no evidence of tendinosis or tenosynovitis. And on dynamic testing, we did not do it, given the patient's location of pain being located more radially. So we're almost there. The extensor compartments, the radiocarpal joint. Then we go on to the dorsal scapholunate ligament. So for this, we're going to start on Lister's tubercle at our home base view, and then just translate the probe distally. And then you'll get the dorsal scapholunate ligament coming in. Radially is going to be your scaphoid, ulnarly is going to be your lunate. Bridging the two, you can see this nice ligament kind of holding the two together. In this picture here, we can see the dorsal scapholunate ligament is a little more robust aspect of the scapholunate ligament compared to the volar. So usually if this is damaged, you have pretty good damage to the ligament in the whole. But we're not able to really see this middle portion, and drawing a blank on the name, of the dorsal scapholunate or the scapholunate ligament. So we're really just evaluating the dorsal aspect of it. So we do a static picture of it, and then we do dynamic imaging of it. Dynamically, I know this has been brought up before, and we talk about it in clinic a lot, so I thought this is a fun time to show the various ways people test the dorsal scapholunate ligament dynamically. So you can do ulnar deviation over that, and that is on this left side of the screen. So here is the ligament being stressed with ulnar deviation. You can have them open and close their hand completely, and that is in the middle of the screen. Or, and this is what we do a little more frequently here, I got to credit to my wife, she told me to use this meme here, is you can have their fist clenched and clench it tighter. And often these are kind of, this one and the fist clench are combinations what you do radiographically to look for this. That's ulnar deviation, the clenched fist view. And because when you clench your fist, it's going to pull the scaphoid palmarly and the lunate dorsally. So if there's ligament damage, you'll see dissociation there. So then for the clenching the fist is tighter and tighter, it looks like that. So I'll let you all compare. I haven't found any studies comparing them and see which one you think gives the best view. I think you might see more separation with the ulnar deviation, but I think it's easier to maintain a pretty view of the dorsal scapholunate ligament with the closed fist, clenched fist view. But regardless, for our patient, the normal, no evidence of tear or diastasis with dynamic testing. And kind of the last structure that we're going to look at is superficial radial nerve. So this nerve we often scan in the elbow, but then we scan it in the wrist as well, looking for signs of pathology and also to avoid it during interventions. So it's got this kind of funky course where it starts under the brachioradialis and kind of courses between the brachioradialis and the ECRL, eventually branching really kind of branching oftentimes at that proximal intersection region into, people call it an anterior or posterior division, or you can keep it as the superficial radial nerve going more anteriorly, and then the one going directly over the first extensor compartment being your lateral dorsal digital branch. So this is kind of the course we're going to be following here. So this is the nerve right here. Let's follow that. So we're starting proximally. The brachioradialis is turning into a tendon. You can see the nerve kind of snapped a little bit there. And as it is going, ECRL is here. And here's that first extensor compartment crossing over the second. So I think things that are important to note here would be right when you're starting to see that first compartment crossing over, if we watch the superficial radial nerve, it starts to divide into those two branches. So this would be our lateral dorsal digital branch. This is the anterior or the superficial radial nerve, kind of just continuing on its regular course up here. So for this video, we kind of follow that anterior branch as it courses. And something I thought was important to include in this spot as well is when you're practicing your scanning, especially that proximal intersection syndrome, right in this region, you can kind of see it happen here, is it snaps a little bit. It's probably from me putting too much pressure. And oftentimes when you're scanning people, you'll feel a little snap and wonder what that was. And usually it's you just putting a lot of pressure on making that nerve kind of go back and forth. So then just kind of completing that aspect of that superficial radial nerve scan. Now we're going to follow that lateral dorsal digital branch. And here's that first extensor compartment crossing over. Here's the nerve. And you can really see it kind of sits right on top of that first extensor compartment as we go distally. So important to avoid with procedures. So normal, no evidence of thickening, entrapment, or focal areas of impingement. And that gets us to our report. So for the reports, we're often going to do the initial portion of it, kind of describing how you did it, where you did it, why you did it, and with what you did it. So facility, the indication, is it a complete or a limited scan? Which part of the body was it? Which side of the body? What are you comparing it to? So we compared it to the radiographs from before. Which equipment did you use? So we used the linear transducer as well as a hockey stick. And the report itself, pretty lengthy, but I would say this is really all that we typed. If you're doing the complete scan for the normal things, you can just have them kind of templated as normal, as long as you're doing the same thing every time. And I just put the abnormal things up top and type those in. I know we've gone over this, but the abnormal findings in our patient was that fluid collection within the second dorsal extensor compartment sheath at that intersection where the third crosses over the second extensor compartment. And that was predominantly around the ECRB with a mild hyperemia noted and no significant kind of tendinosis and no real fluid in the ECRL. And then similarly, there's that small fluid collection around the EPL tendon in that third extensor compartment at that intersection and just distal with minimal hyperemia. And the tendons themselves were normal in appearance without any evidence of tendinosis or tearing. And all the other structures we evaluated and they're being normal, leading us to our impression, again, saying there are sonographic findings consistent with second and third dorsal extensor compartment tenosynovitis at the intersection of the EPL crossing over the ECRB and ECL, with most of the fluid noted around the ECRB and the EPL, such as can be seen in a distal intersection syndrome. And importantly, there's no evidence or sonographic evidence of significant tendinosis or tearing in either of those tendons. So we always do a quick debrief after our scans and procedures, things I could have done differently. I only saved that one Doppler image, so if they're not saved, did it really happen? I find scanning that third compartment in short axis to be pretty difficult. It always takes me a few times. And given the location of pain, looking at the STT joint might have been useful as well as the CMC joint. Then references, and I gotta thank my wife and my scanning partner, Remy here. She's probably already better with the hockey stick than I am. And that is all I've got.
All right, great job, Dave. Yeah, that was perfect. That is exactly what we want from these cases. Great overview of a protocolized scan of this area, and dorsal wrist is a busy area, right, with a lot of structures and a lot of stuff going on. And I thought I thought you did a great job going over everything, and as expected, your images were great as well. So kudos to you. Before I make a couple comments, does anybody have any questions? I don't think Doug's on. Any questions from anybody? I'll give you 6 seconds to decide if you have a question. All right, hearing none. If you do have questions, just unmute yourself. So not a lot to add, Dave. I got a couple points to make, but not much, because like I said, you did a really great job. What I try and do with almost every scan is start with the joint, with a joint. I think you can get a lot of information from a joint, and you know, see certain sonographic findings that can clue you in this being an intra-articular versus an extra articular issue. So for me, with the dorsal wrist, similar to what you did, you know, yes, we always talk about Lister's tubercle, and yes, that is a great home base, and I will usually find that first before going into my evaluation of the dorsal compartment tendons. I will flip and take a look at the radiocarpal joint first. And like I said, I think you can get a lot of valuable information from that. You can look at the dorsal synovial recesses, look for, you know, obviously an effusion, look for synovial changes, hyperemia, that sort of thing. Again, that will clue you into this, you know, potentially being something intra-articular versus not. After my radiocarpal joint, I'll flip back quickly and look at the distal radial ulnar joint. And after I do that, then I go into my my dorsal wrist compartment or dorsal wrist tendon evaluation in the same way that you did. Again, finding Lister's, then I'll slide all the way radial over to 1 and just start my scan there and do it in a very protocolized and structured manner. Let me see here. Oh, one point to make, you know, as you're scanning for intersection syndrome, whether that's proximal or distal, you know, you mentioned findings that you would expect, you know, fluid around the tendon, hyperemia, and that sort of thing. But one thing that I've seen folks do is confuse, you know, EPL muscle belly for fluid, for a large fluid collection. I think sometimes that can be a bit tricky. The muscle, at least the distal muscle at the myotendinous junction, in particular for the EPL, for whatever reason, tends to be a bit more homogeneously hypoechoic, right? Rather than kind of that normal quote unquote starry night appearance. And so I think sometimes that can fool people. And so, you know, I always tell folks and fellows to scan far proximally just to see what happens. Certainly if that's a fluid collection, it should go away as you scan proximal. If it's a muscle, it should certainly get bigger and become, you know, more muscle-like, but be mindful to not confuse those two. In addition, fluid would be compressible. Muscle should not be. So just a point to make there. The two other points, I guess, to make, you know, you mentioned the lateral dorsal digital branch of the superficial radial nerve. That's important, especially with procedures over the radial wrist. I think a lot of times folks just think about the superficial radial nerve as a single nerve, and it doesn't have, you know, branch points. And so knowing that that does branch down there should be important when you're planning out your procedures. And then maybe lastly here, you commented on stress testing for the scapholunate joint and scapholunate ligament. So I tend to go back and forth on these. You know, I will start with the clenched fist view, and then I'll have them do radial and ulnar deviation. I think what you said was spot on. I think it's certainly easier for the patient just to clench their fist, and it's easier to stay on them that way. But I have found that you can get a bit more torque and a bit more stress across that ligament when you have them forcefully ulnarly deviate. So at least in my world, I think that's probably a better stress view, but it is a bit more challenging. I think that is all that I have. Yeah, I think that's it. Let's see, anybody else questions? I don't think so. Cool. All right, Dave, great job. That was spot on. Like I said, it was a great overview, great pictures, great case. And thanks for doing that this morning.
Yeah, thank you.
All right, guys. So since we are off by a week, we are not off next week. We are back on next week. So April 22nd, Alex and Wen's given a case, or our discussion of a case of quadrilateral space syndrome. So again, that'll be next week, April 22nd, and then we're back on schedule with our every other week schedule after that. So thanks again, Dave. Everybody have a great rest of your week, great Friday, great weekend, and see you guys next week.